Hi, this is Brian Kim. I want to share with you case number 270 in the best way to do cataract surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. So this is a cataract that's white and intumescent. And you're going to see I'm going to place trypan blue and then using a needle technique to aspirate the fluffy, milky material to decompress the anterior capsule in the bag, and then performing a two-handed capsule Rhexis technique, and then double chop and cross chop. So I'm using the cotton tip to steady the eye, and then using a corneal marker, which will help me to center and size the Rhexis. Using the same cotton tip, I'm steadying the eye to make my paracentesis incision, first on the right side and then the left side. Using that cotton tip again to control the eye, trying to get a flat approach. You want to make sure you're nice and parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. You can see this is a right eye. The patient has quite a bit of a Bell's reflex. Injecting some intracameral epinephrine and then some intracameral air. You want to burp the aqueous out of the eye and then put the air in. And then this is trypan blue, painting the anterior capsule surface, using the cannula to basically swipe side to side. And this is some dispersive viscoelastic. And pushing the air as well as the dye out through the paracentesis incision. And holding the eye with the cannula, since the patient has a strong Bell's reflex. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then when I'm ready, I dive in. And then now I'm going to place a 25 gauge needle through my superior paracentesis incision. I'm going to puncture the center and then aspirate very quickly. And as I do this, you can see some of that liquidy lens material being aspirated. You can see the relative flattening of the anterior capsule surface as well. And you can rotate your needle as you do this. You can have the bevel facing the left, and then you can roll it towards the right, making sure you evacuate 360 degrees. Placing the dispersive cannula back in the eye. And I'm going to keep that cannula in there for two reasons. It helps me control the eye, but then if I start to feel that the chamber is collapsing, I can push more viscoelastic, as you see here, to help keep that chamber as I do the Rhexis. You can see I'm going clockwise now, and why is that? Because of the way the tear went. So in this case, the tear wanted to go clockwise, so I just follow the tear the way the tear wanted to go, instead of going with my normal technique of going counterclockwise. You just have to be flexible in these situations. So again, pushing more viscoelastic simultaneously as I'm doing the Rhexis. So a two-handed Rhexis technique in these situations to help keep that chamber nice and stable, and then using those Moria Rhexis forceps, which are really, really great. It minimizes OVD egress and really helps minimize radialization of the Rhexis. So this is the capsule fornix hydrodissection technique. I place the cannula under the Rhexis edge contra-incisionally. Of course, these lenses are already loose anyways, so I don't really need to get a wave, and you saw I was able to spin it rather easily. Lifting the incision with the chopper, going in with irrigation off. Lifting the iris edge with the chopper to minimize reverse pupillary block. Placing the chopper under the Rhexis edge contra-incisionally. Hooking the phaco-tip vertically sub-incisionally, fracturing the lens in half. That's the double chop. Placing the chopper under the right heminucleus, hooking the peripheral lens, pulling it centric toward the phaco-tip, and then fracturing it in half. Using the phaco-tip to lift that first quadrant up. It kind of turned a little funny. Performed another cross-chop maneuver, fracturing the lens piece in half. Doing that again, and emulsifying each of those fragments. This is a chalky lens, so it's not super dense, so it's rather easy to fracture the lens pieces. The trickiest thing about these cases is really the Rhexis. So doing that decompression technique with the needle is very helpful. But again, lens disassembly is rather routine for these cases. The lenses are rather soft. So again, hooking the peripheral lens with the chopper each time, placing that phaco tip deep, and then fracturing the lens between the instruments, using some vacuum to grab the pieces, and then again, sandwiching the lens with the instruments, crushing it into smaller pieces, and then emulsifying the lens pieces. Again, you can see as I'm crushing the lens, I don't activate any vacuum or ultrasonic energy, but then once the lens pieces are small enough, I eat it up. And most of the time when I'm eating it up, it's mostly vacuum that's being used to eat the pieces up with small pulses of ultrasonic energy. Once most of the lens pieces are out, you want to be very careful. You want to avoid post-occlusion surge. I keep that chopper rather deep. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the ironing handpiece. You can see this material is rather soft. This is the epinuclear material and the cortical material. Really soft stuff. So again, pretty standard for an intumescent white lens. There is some cortex there, but again, rather sparse, more stuck in the periphery there. Switching to polish mode, polishing under the Rhexis edge. Pulsing BSS into the subincisional capsule fornix. And in this case, there is some lens material that's trapped there. So I like to pulse it. It comes right out. You'd be surprised, unless you pulse, you don't really know. Unless you look, you don't know. It's really important for you to be compulsive about removing all that material. Turn off infusion and then pushing cohesive viscoelastic to fill the bag. Polishing under the Rhexis edge, subincisionally with the sweeper. And as I do this, you can see there's a bunch of lens material that comes out. So those are the two things that help me with the subincisional lens material. Pulsing with the BSS cannula, which I think loosens it up. It either gets rid of it when I pulse it, or it loosens it up, and then I can use a sweeper to go after it. So I feel very confident that the lens is completely been removed, including this fines lens material from the capsule fornix. So this is a single piece acrylic lens. Nowadays, I like to push viscoelastic in first before I put the lens in. So that's a little bit different from what I do now. Again, this is an older case. I'm dictating and narrating this quite a bit later now, but I like to add more cohesive viscoelastic to the bag before I put the lens in. So I go underneath the lens, removing all the viscoelastic from within the bag, and then polishing under the Rhexis edge. And then I'll remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, a white intumescent lens. The key is puncturing that central anterior capsule. You want to fill the eye with dispersive viscoelastic, flatten that anterior capsule, puncture the center with a 25-27 gauge needle, quickly aspirate the center. You can see that milk quickly evacuate, and it'll flatten the anterior capsule. Once you do that, you can fill the eye again with some more viscoelastic. And what I like to do simultaneously is have that viscoelastic cannula in my left hand through that superior incision. And then as I'm doing the Rhexis, if I feel the chamber's collapsing, I can push more viscoelastic simultaneously, as you saw in this case. So having two hands is very helpful in all steps of the case, but definitely in this case, doing a two-handed Rhexis is very helpful, because when you have a two-handed Rhexis, you're able to fill that anterior chamber, flatten out the capsule, reducing the risk for run out, And then having those micro Rhexis forceps were rather helpful. And then you saw me perform double chop, cross chop mechanical fracturing. Again, not a really dense lens, leveraging mechanical fracturing forces to eat the pieces up into smaller pieces and then emulsifying the piece. So this case was rather routine, even though it was an intumescent white cataract. So I hope this was helpful to you, and I thank you for your attention.